may I ask the panelists to come to the podium? And I think while they are in preparation, they are preparing, get a little bit of information what's about hearing and about the aim behind this experiment, which we have done a few times before. And we will focus in this roundtable on tympanoplasty around the world. We have a lot of discussion in the morning where different aspects were discussed, and we thought about separating the tympanoplasty into four phases. We have five speakers. I forgot one. Yeah, you were late. Xavier, forgive me. By the way, he's the vice president of the Hearing Network, but anyway, we can forget him. Copy paste. We have no conflicts of interest, and Hearing is a group of 36 comprehensive hearing centers around the world. And as I said, we want to address the different aspects of tympanoplasty, which, as a German proudly is announced, comes from Wollstein 1952. We will discuss different materials, and we will have a first lecture on the opening by Dennis. He is not chosen by chance for that, because he is French and he loves end-oral incisions. So we want to have some controversies, and then we will have a discussion with you about the aspects and questions. Then Prep will describe transplant and implant materials, which are also used differently around the world. About the reconstruction of the prosthesis, we will hear Robert Vincent and Javier, whom I forgot it in the introduction, because he has the most important topics. He will put the finger on controversies and how solutions could look like, and I will talk a little bit about aftercare. The idea is to have 5 minutes impulse presentation and then 10 to 15 minutes of discussion and questions with you, and hopefully each aspect will give some information to take home for everybody of you. So I'd like to welcome Dennis. Yeah, oh.
Okay, so Joachim asked me to speak about external surgical approaches. So to the middle ear and mastoid, we have three external approaches: the transcanal one, the endoral, which is usually minimal, but you can extend the endoral approach on the retroauricular. Then the regular retroauricular approach. For choosing what is the best, you have several criterion, like size and location of the perforation or retraction pocket, the presence of cholesteatoma and or the need for a mastoidectomy, the ossicular change status, and the anatomical consideration that you can see with your otoscope or with the imaging. For the retroauricular approach, in the department, we use this approach for all the cholesteatoma surgeries, except if we use the endoscope, for the large perforation extending anteriorly to the malleus handle. Okay, for revision surgery or the need of for wide exposure, and also if we have to harvest cartilage from the pine, we prefer to do the retroauricular approach. For the endoral approach, we use in the department the endoral approach for working on the posterior part of the tympanic membrane if we don't need to reinforce the anterior part of the tympanic membrane. For ossiculoplasty, and in case of narrow canal that limit the exclusive transcanal access, but we perform very few transcanal access. The exclusive transcanal approach, we use that in the department for quasi-exclusively trans-tympanic fat meringoplasty. Okay, but when you see the skills of the player in Marseille, you can see that you can go, you can do a lot of things if you have been trained for, because it's difficult. It's difficult. That's it for me, so we can launch the discussion.
Yes. What are the opinion of the panel? Please comment on either way of incision.
Well, in the clinic, also with
Tu le mets à côté.
and so we use especially transcanal for, as you said, tympanic membrane perforation, including I use for anterior perforation, but it's a personal view. You have to drill out the anterior wall, and the problem of drilling out the anterior wall is the TM joint. You have to be very careful about that. You never know exactly how to approach, but it's more transcanal. I know Thibaut is using more posterior, and I don't think you use endo, Thibaut? No. So we use transcanal or posterior.
Thibaut, why no endoral?
First, because I was not teach for that. I never performed endoral approach in the Portman school. It was transcanal or posterior approach.
Javier, what's the situation in Spain?
Well, I don't know what's in Spain. We have more Spanish here to speak about, but I can tell you what's my experience. I'd rather have, for tympanoplasty, I'd rather have retroauricular, postauricular, for stapedectomy, transcanal, and sometimes, very few times, endoral.
Well, in Asia, I think more and more people are doing endoscopic transcanal. Even if it's a subtotal perforation, people are moving towards endoscopy now. And the younger generation who grew up with PlayStations and whatever not are very comfortable in endoscope. So the vast majority of people in Asia are doing endoscopic for TM, simple myelingoplasties. So the post-auricular will always be whenever there's mastoidectomies and things like that involved.
So we have the younger people in the audience. So are you trained with PlayStation to be trained in ear surgery? Who has a PlayStation at home to be trained? Any programs available?
You're young, I see.
My son.
Yes.
Okay. You want to comment on that?
I think absolute transcanal is possible, is feasible for almost every meningoplasty, almost all tympanoplasty, but I with you that sometimes, in my case, when I perform ossiculoplasty or I perform stapedectomy, I use the microscope. I prefer it transcanal, but with the microscope. It's a matter of still going transcanal, but with another tool.
The approach is the same. The tools we use may be different, but the approach is the same.
Questions regarding the approach from the audience? Everything is clear. What would you use? Please. Pardon?
But does it matter? Miguel?
Yeah, just. You want the microphone?
Yes, there was a
Oh, just
gentleman
a
at the
moment.
back.
No, first
yeah.
you and then...
Okay, just a matter of terminology, because transcanal is through the canal, and through the canal you can go endocanal, and you can go endocanal like Robert Vincent with a speculum or with an endoscope.
Yeah.
And you can go transcanal endorally, and you can go transcanal retroauricular. So I think transcanal is just to the canal. Endocanal is when you are going inside the canal with no incisions, no external, no endoral.
What do you mean by transcanal retroauricular?
Yeah, because you do retrograde incision, but you are only working transcanal, just through the canal. That's the terminology. I mean, it's something. Sorry.
Take the microphone, please.
I think it's just a semantic. Permeatal is a term that's used for, transcanal, as we're using it, transcanal. But permeatal is through a speculum, or it could be an endoscope. Transcanal incision.
I think the most important thing is correct. Someone say there. Most important thing is adequate visualization so that you can deal with the disease, and that's where you have to alter your approach, possibly, to get adequate visualization. And the endoscopic surgeons feel that they can get that endoscopically most of the time. In Australia, there's a lot of patients who have a degree of exostoses, narrow bony canals, and need a generous canalplasty as part of the procedure. And that's a good reason to either make an endoral approach or a post-auricular approach, I think.
I guess at the end of the day, it's whatever works in your hands. So as long as it works, the end is justified, I think it's fine.
I agree that whatever works, but it's not exactly true, in my opinion, that looking down the canal with a microscope is the same as looking down the canal with an endoscope. For example, the anterior bulge that I grew up with, so I grew up with transcanal when I took over from John Oates at Burton. But now I do most of my middle year stuff with the endoscope, because the anterior bulge almost stops being a problem when you use the endoscope. And I also work in New Zealand, where we have a lot of exostosis. It never is a problem with the endoscope. You get a far superior view, I think, of the middle ear with an endoscope than you can get with a microscope.
Yeah, I mean, that is a question of training. I like the structure of Dennis, because I'm older. I never used the endoscopes for middle ear surgery because of the binocular view, but I've learned and heard that you can get an assessment of the depth, but visualization and choosing the proper approach, I think this is the key. And
I think when we started ENT, my first 1-2 years, we didn't have an endoscope. So we were doing catwalk block, we were doing even nasal surgeries with a headlight. But subsequently, when the endoscope came about and everyone examines the nose, I'm talking about the younger residents and all that, with a camera system. So in their mind, they're already used to seeing a 3D anatomy in a 2D camera system. So when they move, that's what they were exposed to from residency. So when they move to surgery itself, looking into the middle ear space with an endoscope onto a flat screen, they are able to convert it into their mind to 3D because they were exposed to it in the very beginning. So I think it's about what you're used to, what you're exposed to.
Can I ask a question to the audience?
Yes, please.
How many of you are using routinely, let's say at least 50% of the time, endoscopes for the middle ear surgery? And how many are not? So it's still more not than...
Yeah, but how many of those who are using routinely endoscope sometimes have to move to microscope? How many of you? This is important. It means that you need to learn both techniques. Yes. Because if you learn only the endoscope, then you have a problem. If you don't know how to use the microscope, then it's becoming a problem, especially for the cholesteatoma, I guess.
Well, I think that's what Dennis said. No, that was a sign for me to go to the next speaker.
Sorry. You need
the secret charming person behind.
You make the better choice.
But I think what you said, that the endoral approach can be extended. So depending on the pathology, you start with an endoscope and end up with a microscope, or modify the incision. So we have a common sense. Everything works. And maybe the choice of approach has to do with the pathology and with the transplant and implant materials that you want to use, and to hear a little bit about the different materials, hopefully creating even more controversial discussions with PrEP. Thank you.
So I do skull base for a living, but now I'm going to talk about tympanic membrane reconstruction. So the topic that I'm going to speak on is actually the tympanic membrane reconstructions and what are the things we use. So we know the tympanic membrane is 9 millimeters in diameter, that is 0.1 millimeter in thickness, 3 layers, epithelium, fibers, and the mucosal inside. If you have a perforation, it can heal spontaneously, which means that the fibrous layer is missing. You get a much more thinner epithelial and the mucosal layer. We can repair, and the idea of repair is basically to have a scaffolding. So the idea of repair is to have a scaffolding. We did some work for the epithelial migration, so these are the publications I've had. So one of the things we looked at was to see the epithelial migrations on a normal tympanic membrane and compared to a post-tympanoplasty tympanic membrane, and we found that the epithelial migrations were identical. And these were the times when we were using only the temporalis fascia. And we also found that the attic pockets have got slower migration, especially when the perforations are, or the pocket is small. That's why you have keratin buildup. So what we need is a graft that provides a scaffold for epithelialization. So we need something that is biocompatible, something that will give a similar acoustics to the native structure, and also last long enough for epithelialization. Now we can divide this into autologous. The most common one will obviously be the temporalis fascia, the cartilage, perichondrium, vein. Fat, I've had a few patients with small perforations after fat tympanoplasty where they cough, they sneeze, poop, it just goes off. So fat is not something that I'm very fond of. And if you look at, there are some newer things as well, like hyaluronic acid, platelet-rich fiber. Now all these are way out of reach for the guys in Asia. Yeah, life is not that easy for us, so this is completely out of the way for us. So either temporalis fascia or cartilage and perichondrium. So this is probably a busy slide, but this is probably explains the best. The most widely used is temporalis fascia. It's got a low metabolic rate, high collagen rate, is easily accessible and available, and the success rate is quite high as well. The good thing about this is it doesn't damper the sound transmission, whereas cartilage has got a much higher success rate. However, it tends to be thicker. Therefore, there's much more sound loss compared to temporalis fascia. So again, if we look at a simple diagram, would be temporalis fascia will be easy, effective, low rejection. Cartilage is good for retraction. However, the sound loss is quite significant as well. So my personal choice, if we need, what we do in Asia is if we need to do a ossicular reconstruction, then we will do a cartilage because we will use the thin perichondrium for the tympanic membrane, and the cartilage will be available for reconstruction. That's what I usually do. And it's because I do endoscopic for middle ear, so most of the time I will take a cartilage. Life is difficult. Let's keep this simple. Thank you very much.
Well, I'm not sure if you have kept it as simple as it might be. What are your preferred materials, Robert?
I prefer perichondrium. As you said, compared to cartilage, because it's much thinner, elastic, and it's easy to use, and it's healing very well. Cartilage I don't like too much because I could see that there are several cases of some residual hearing loss. But it also depends on the way you use cartilage, because if you trim it very nicely, then it's better. But some people use the cartilage. I saw that, like this, and just put it in the middle ear. It's very bad.
But it heals very well.
Yeah, but the sound is not good. And then when you revise that, it's just a nightmare. So.
Well, I totally agree with Prepa for the first time. Well, I think in my hands, what works better is fascia, temporalis fascia. But if the perforation is big and you need some more support in the attic or something like that, cartilage is the top. I mean, it goes very well as long as you do it thin, just to avoid a big block on the ear. And perichondrium only when I don't have a retroauricular incision and I can have a harvesting of the perichondrium. I may use perichondrium, but I prefer temporalis fascia as a routine procedure, unless for large perforation.
Dennis?
Well, I guess I didn't use any more the fascia, except for revision if I need something. I always use cartilage, thinner cartilage, with perichondrium for tympanic membrane perforation.
Yeah, tympanic.
Okay. Yep.
Does it play a role
Well,
as?
in fact, I was with my mentor at the end of the 80s, and we started the cartilage use with full thickness cartilage, okay, for residual perforation, revision, for retraction pocket, it's normal, and then we moved to cartilage all the time. All the time we use cartilage in the department.
As Prep has discussed, he made a difference in the tympanic membrane repair if he needs to also reconstruct the ossicles. This will part of the next talk, but does this affect the choice of your material?
Yes, the good thing about post-auricular and endoral is you have everything in front of you, the muscle, the fascia, the cartilage. So if you're doing endoscopic and you need to harvest something, so you want a minimal, there's no point doing endoscopic if your incision is going to be big. The entire reason of doing endoscopic
this
is to have
speaks
minimal.
for post-auricular incision instead of transcanal to have the materials ready.
Exactly. Yeah, but then you can always do a tragal, a small incision, and you can take the perichondrium and the cartilage, and it's adequate for you to do whatever is required.
Well,
we don't have the money that Europe has got for all the prostheses and whatever not. So we have to rely on the cartilage.
If you what would you prefer, tragus or contra cartilage?
Tragus, yeah.
Why?
Maybe I'm just more used to tragal cartilage. I think it all depends on what you are experienced to. And the tragal cartilage has got some amount on concavity as well. And that can be quite useful for you to reconstruct ossicles if required.
Questions regarding transplant materials from the audience?
For the question of tragal or concha, okay, for the cartilage, I think that tragal cartilage is better for tympanic membrane reconstruction, and the concha is better for canal wall reconstruction because it's the curve.
Yeah, I agree. This is a good point. And for the tragus, you have perichondrium on both sides, and you can peel off one side, and you double the size of your transplant.
I was doing that 15 years ago.
Okay.
No, I changed because when you
butterfly,
the cartilage, and if you want to thinner the cartilage, it make a chips.
Yeah.
So if you want that your cartilage stay plan, you have to remove all the perichondrium. All the perichondrium, I guess.
To avoid...
I used the cartilage in full thickness at the beginning, okay?
Yeah.
But it's more difficult to manage that when you make chips of cartilage that you can put in a mosaic.
Yeah.
Okay. About, you said the acoustic properties of cartilage. I was 15 years ago, maybe 10 years ago, with the colleague from Cologne, Untenbrink.
Yeah.
Okay, Untenbrink made a lot of works on the acoustic properties.
Yeah.
Okay, and he said you have to cut the cartilage 0.3 or 0.6 to have the better results. And in a meeting, I presented the cartilage myeloplasty in full thickness. That's what we were doing at this time. And during the meeting, I said, I don't understand, Carl. You said, but with our technique, we have very good results. And he told me, yes, what I told is in the lab, but on the patient, it works.
Right. So, Manoa, yeah. Comment on the middle ear mechanics and the tympanic membrane.
Yeah, I mean that's exactly right. I mean, if you look at I did a ton of this work in middle ear mechanics as well, and we did a whole series of publications on thickness of cartilage and where you put it, and it does make a difference in the temporal bone lab. But clinically, all the systemic reviews seem to show equal results in terms of where it makes a bigger difference is if you're touching the edge of the annulus. If it's in the center, you can put a concrete block in. It doesn't matter because you've got nice. It's really the baffle effect that you're trying to avoid. So it doesn't matter if it's near the center. But if you're going to touch an edge, then having a flexible boundary can have an effect on the low frequency.
Of course, usually we don't touch the edge, and I performed the hyaline cartilage like Dornhofer, I think.
Yeah.
Okay. But it's very difficult. And it's difficult to transmit to the young surgeon.
Yeah, please, question.
So regarding that touching the edges, what we usually do is we slice the cartilage. We remove one side of the perichondrium. We slice the cartilage, and then we remove part of cartilage from the edges.
Yeah.
It's like an island. So that perichondrium part we rest on the canal wall, and the cartilage part stays in the middle. So then it's not touching the bone, and it's not hampering the movement of the cartilage, and then it's perfectly fine. The results
This
are
is
good.
perichondrium cartilage island technique described by Milewski, 82. But that's what Manoa said is important, that if you have a fold in between the annulus, this is similar to what Bekeshe described as a movement for the regular tympanic membrane and the model behind, and that works. Questions from the audience, comments?
I just want to know for each of you, can you put the before slide before of this? Yeah, in that big perforation, I just want to know for all of you the approach and what do you use, and if you use cartilage with perichondrium or just cartilage.
For me, with this situation, I make a circular incision in the canal, and then I will use a bed of connective tissue, perichondrium or fascia, but I will put cartilage on this bed, this hammock, and then put connective tissue in front of the perforation. It's like a McDo. It's a hamburger.
Without gel foam.
Without gel foam. If I need to support the cartilage, I use the thin cartilage, which I put majorly to the graft. Okay, we call that the bending cartilage. Okay.
Prep, what would you do for the lower case?
So, assuming the ossicles are intact, we will use perichondrium with a very thin layer of cartilage in the center, and the success rates are very good. With the cartilage and perichondrium, I think they last longer. The scaffolding of a perichondrium and a cartilage lasts much longer and allows epithelialization to occur. A temporalis fascia maybe does not last as long, and maybe that's why the scaffolding it provides is not long enough for the epithelium to regenerate itself.
I will also use postauricular incision, cartilage with perichondrium, and I think it's extremely important to revitalize the edges of the perforation in such a large perforation, because otherwise you will not get a healing. But if you use cartilage with a perichondrium unfolded, in my hands, that works much better than before using gel foam and temporalis fascia. That reperforations or remaining perforations, even smaller, were the rule.
So what I do in this case, I do a 360-degree incision, elevate the whole flap, and remove the whole flap. And I call it total flap removal. So then I have the bone and I have the ossicle. Then I put my graft over the bony canal wall, over the malleus sandal, and over the bony canal wall. And then I reposition the tympanometal flap. I call that the total flap removal. And when I was starting to do this, I was thinking that I will have the problem of lateralization of the, and I had few cases. And then Benoit explained that the way to decrease this risk was when you put back the graft and then the flap, you have to fill the entire anterior angle, even the canal, with gel foam. So I put now 3 silastic sheet, 1 in contact with the graft and 2 around the canal, and then I fill completely the canal. I think you saw that with gel foam to hold the graft in position, and then I put a mirror cell.
Just to be clear, you remove the whole skin.
The whole, yeah. It's like a skin grafting, a free skin. Yes.
Okay.
Well, I think the problem with lateralization of the graft is it's after time. So it's even if you keep it at the beginning, there it will.
No. I had the big difference, really, before and after this technique. When Benoit trained me and explained to me how to do it, when I started doing it, I decreased a lot the incidence of lateralization. Of course, I have some still, but not the same amount. It keeps in contact for some time. So. And I thought there could be some necrosis of the skin also when I was doing it, but there's no necrosis. I never saw it.
No, that's surprisingly. I just want to add a comment. Robert pointed out an important thing. That's the anterior annulus. And one dogma in our school was not to touch the annulus. And many schools have this.
It's a German school.
Yeah. But sometimes when you grow up, you move away from your school slightly. And what we did is also to remove the annulus, put the overlapping perichondrium, like Müller described, underneath in the bony annulus, and then the important thing is what you said, to replace the annulus in the same position, and then you have no lateralization. So that's the key point, I think, in this perforation, to get no reperforation to be fixed anteriorly. And for that, I would use the post-auricular incision. But there were questions from the audience and comments, please.
In defense of the endoscopic surgeons. Can you hear me?
Yeah, what materials would they use?
We use biodesign, which is dissolvable, or thin cartilage with perichondrium from the tragus.
How you get underneath the annulus with the endoscope?
Yeah, you make a little pocket anteriorly, so you don't lift the whole eardrum, you lift about 80%. And then you make a little pocket anteriorly and pull
through.
And pull through. Yeah, that's a little.
Pull through, Gerlach. Yeah, please.
Sorry, my question is similar. I would like to ask the panel about their experience and their thoughts about using the synthetic or biological graft like biodesign, which is quite common with endoscopic surgeries, endoscopic tympanoplasties.
I have no experience. What is your
experience? I haven't any experience, so I don't know.
I use artificial material, Leodura, they call it a long time ago, and it didn't work well. I mean, if you have natural material, fascia and perichondrium works much better than artificial tissues.
I don't think we can afford very much of this artificial material, but we are open to donations if you would like to donate any to us.
No experience. No experience.
No experience. Okay. Please, last question, and then we move to the next topic.
Thank you. Double question. Do you think poor eustachian tube function has a role in failure rates? Does it influence your graft choice? And do you think there's ever a role for balloon tuboplasty concurrently with tympanoplasty? 3 questions.
Absolutely.
Yeah, absolutely. But the problem is that when you have a perforation, you don't know about the eustachian tube. So you know about the eustachian tube when you close the perforation, most of the case. So it's a problem. When you see the retraction, it's one of the major causes of failure. I'm sure about that. What? So would it?
How can you assume? Yeah, please.
Yes.
So would you lean more towards cartilage in that scenario?
One of the first thing and the most basic, take a look on the contralateral ear. Good. And the second one, we have been following I would say, more than 600 patients with chronic otitis media like that. And we came to the conclusion that you have two kinds of perforations. The first one, like that one, it's inside-out perforation. It's like an accident. And like the second, kind of like the second one, it's outside-in perforation because it developed from a retraction. And this is much more complicated to treat, and that's why I think the cartilage is a good idea, because it's the most resistant graft to hold the possible pressure, negative pressure. Of course, we can't say for sure that there is the eustachian tube dysfunction, but you can assume if you have both ears, that you have the patterns of the outside-in perforation, that probably the function wasn't that good at some point in the life. Well, again, you can look to you see, they are completely different. You know, if you spit in the first perforation there, it's going to close. And the second one is a different ballgame.
You can also look at the CT scan if you have one, because if it's pure pneumatization of the that they must have had poor ventilation during growing up. So if they've got good pneumatization, they've had good eustachian function.
But if you're uncertain, I think general agreement is that cartilage would be in the big perforation a good choice.
A lot of people do this in the US as an overlay technique. You know, just lift up the whole outer lip. Yeah, lift up the outer connecting lip.
Let's make the same mistakes like in the 50s. Please. Last question and then.
Thank you.
Last question and final comment.
The last question is, at what age do you prefer to do a pediatric tympanoplasty? Because I think the age is problem for recurrence of diseases, for re-perforation.
Yeah.
Do you, before tympanoplasty, provide any surgery of the nose, nasopharynx, I mean adenectomy or no?
Let's start with the answers from the panel.
Of course, if needed, to treat the nose before treating the ear. First, for the age of children, there is no question if it's a retraction pocket or cholesteatoma or whatever you want. And for the perforation, in France, we are used to wait about 7 years. After 7 years. Hold.
Usually, we will have to treat the nasopharynx first. So if the middle ear space is dry, then we can assume that the tympanic membrane, the eustachian tube is functioning. If there's a persistent discharge from the middle ear space, then you have to assume that the patient has got some amount of nasopharyngitis or adenoiditis or adenoid hypertrophy. Then you probably have to give some nasal steroids and so on. So it all depends on the case, but we will not operate below the age of 7 or 8.
We neither. I mean, we don't think the nasal surgery is really having a serious background for doing that. I mean, I don't know if other than charging twice, as you said before, it's any other reason for that. And again, if it's a big disease, it's cholesteatoma, you do it anytime you need. And if it's just to close the perforation, we wait until the age of tonsils to adenoids retract, so it will be like 7-8 years of age.
What?
I'm sorry to say that I have to agree this guy supporting the PSG.
Well, I have a comment on that. We did an analysis of our tympanoplasty database with Helms in 1999, and we found no difference in reperforation rate depending on the age of the children if we do it at 5, 7, or after puberty. That was surprising because TOS reported other situations. So for us, the age is not important. What we do is adenoid removal prior to surgery if there's a clinical course. But from that, the only criteria is that the child is cooperative for aftercare. But we could not confirm that depending on the age, we have higher reperforation rates. So with 7, we are fine. Maybe if the child is a little bit more behavioral than 5. And for cholesteatoma, as Dennis pointed out, anytime you have the diagnosis. Okay, then keep the questions. After the next talk, we will hear about ossiculoplasty and how this may affect our procedures.
that's the point. And I fully agree with the comparison between mechanics in the lab and mechanics in life. And what I'm going to show is the way I do it in very fast presentation, if I can. And it's, I mean, whatever type of material you use, I think it's more or less the same. That's what I think. It's a question of stability for me, which is the most important thing. And what was driving my experience and my evolution in these techniques of circular reconstruction was to find two things: the ways to stabilize the prosthesis, how to fix it, because it's a nightmare when you do this reconstruction and you have a recurrent prosthesis dislocation, whatever you do. So I was thinking a lot about this point. And then the second point was to place the prosthesis also in a vertical position, because we know that the more we put the prosthesis like this, the more is efficient. So I'm going to go through the different situation, and I'm using a classification for that, the Austin cartouche, which is not a perfect one. There's no perfect classification because there are so many different types of ossicular problem. Like, for example, when the stapes superstructure is absent, eroded, there's no classification for that. So it's a complex one. So basically, we could say that in group A, when malleus and stapes are mobile, in the past I was using PORP, and I moved progressively to TORPs because I was following Bill Moretz from the US, who was one of the first to introduce the possibility to do that despite the presence of a stapler large. So I do a TORP now for Austin cartouche group A, and I never use, or nearly never, PORP. But that's, again, a personal view. And I compare my results before and after, and my results were published, and my results were better in my hands. So I moved to TORPs. Like, this is what we call about a tilting movement. When we put a TORP like this, it seems to be fine, but there's a tilting, lack of energy. It's clear that with the new PORP, with the clip PORP from Medel and other one, and Kurtz, they are much better. And I prefer hydroxylapatite because, as I said, you don't need cartilage in deposition, and you don't need cartilage in deposition, and you can trim it. But that's, again, a personal view. For Austin cartouche group B, I use TORP. There's no discussion about that. I mean, everybody agree. But I know that some people don't use malleus handle, and that's one of the, I think, important point. Do we have to use malleus handle? My answer is yes. I think as soon as we have the malleus, we have to use it. But that's the personal view. So, for example, in this case, this is a group B with a mobile footplate without any residual ossicle except the malleus. There is no superstructure. So for sure, I will put a TORP with the malleus relocation that I described this morning. So you saw it. So by repositioning the malleus, we put the malleus over the footplate, and then we can measure accurately the distance from malleus to footplate, and then we can cut the prosthesis. I'm looking for this kind of thing at the end. Whatever type of prosthesis you use, in my opinion, if you use a TORP, you need to find stability, how to fix it. This is why I use prosthesis with a groove at the prosthesis head, and how to stabilize. But if you don't have stapes superstructure, there's no way to stabilize the distal tip of the prosthesis. Even if you use the shoe, like Kuntenbrink was introducing it, the problem is how to stabilize the shoe. It's a different thing. It's always the same thing. I know that some people, when we have that, do a stapedotomy on a mobile footplate. But sometimes I do it, very rarely. The group C is when you don't have any more malleus and having a mobile stapes. So for sure, you can move to PORPs or TORPs. And for the same reason, I use TORPs because I introduced the sylastic bending technique. So I stay in the same direction because I was able to follow my results prospectively with my database. So I never came back to PORPs, in fact, except when we got a very small distance from malleus to stapes footplate. Then in that case, if it's less than 5, I prefer to use PORP. So sylastic bending, maybe tomorrow I will describe that, but I'm sure that many of you have you seen my technique with that. So that's the point, to stabilize the prosthesis. Again, the group F, I'm going to go through this without any description. We all know about that. We do stapedotomy and malleus to stapedotomy if there is an eroded incus, like in tympanosclerotic cases like this. And as we discussed, the problem with tympanosclerosis is that we have a completely different situation completely different than otosclerosis, because it's huge, frequently not completely hard, but it's really harder than obliterative otosclerosis, but I use the same technique, enlarging the draining out until I approach the membrane and then opening up the membrane at the end and then put in a torp like you saw this morning, but in a regular fact. And then again, because I've relocated the malleus again at the end, I introduce the malleus within the groove and I have a vertical position. Always the same thing, stability and efficiency. And finally, the group D, which is the worst situation, when you don't have any more malleus and any more superstructure, only have a mobile foot plate, there's no way to stabilize this prosthesis. You put a prosthesis directly from tympanic membrane to foot plate, and for me, it was a nightmare. I tried to find a solution for that. Some people would do stapedolomy on a mobile foot plate, but I think it's not really good. It's only to stabilize the distal tip of the prosthesis, but you cannot stabilize the head. So that's the reason why I was introducing the malleus replacement prosthesis, you know this one, to rebuild the new malleus, to recreate the point of stability. And interestingly, when I create this malleus replacement prosthesis, it's only because I didn't believe in mechanical effect of the titanium. But I was thinking of putting a new malleus when the malleus was missing to stabilize the prosthesis. So I'm using it as a stabilizer, if I can say that in English, to stabilize the position of the torp, to fix the torp to a new malleus handle. That was exactly the idea that I was thinking about. I know that Fish was thinking about another different technique, but it was a very complex one, didn't work well. But of course, at the end, you can see the difference. If you put something to rebuild the malleus, at the end, you change the group, and you move from group D to group B with a better chance of success. So thank you. That's it.
Let's say a little bit about stability.
I'm not so stable after seeing this presentation.
Oh, you don't use prosthesis?
I do, but we usually only for those who can afford it. But I think that's a fantastic presentation. I don't think I'll be able to reproduce anything like that.
Me neither.
Questions from the audience? Yes, please.
Well, my question is regarding staging. To stage or not to stage the surgery? Like if you have a large perforation or a diseased mucosa, what's the rationale to, I will do the reconstruction or I will stage for another moment?
This is my topic. This is the controversy. No, but we can go on. We can go on. I mean, all of them are my topic. So
if I have a perforation with a stapes fixation, I stage. And in the most other situation, I don't stage. I mean, what is the risk? If you have a dislocation, then you can do a second stage, I would say. But if you can avoid the second stage, do it in one stage. That's what I mean.
Well, I was trained that you will never open the inner ear in an infected ear or an open ear to the outside. So I will never do a stapedectomy at the same time as a tympanoplasty. And concerning the other staging, well, it depends on a lot of different factors. I mean, it depends on your patient. It depends on the disease. If you have a cholesteatoma and you're not sure whether you remove everything or not, but the patient lives 5,000 kilometers away and will not never come back, so you have to do everything in one stage. Otherwise, you may stage the operation. So it depends on so many factors that this is why we are still discussing about that after 45 years.
In fact, I do the same as you, but there is no evidence that it's mandatory not to do stapedolomy with a perforated eardrum. We think it's better to stage, but there is no evidence because the risk is infection, but infection they are already in the middle ear. So I mean, it's just.
But I mean, this is why I said I was trained with that because I'm not sure whether
it's
this
better
is right
because
or not.
if you go in front of a judge, the judge will ask you why you.
You did open the
medical equalities.
I have a question. Yeah, please, audience first.
Yeah, my question is again with the panel that with the ossiculoplasties and even stepedotomy, what will you call success in terms of audiometry? And also, I mean, subjectively, if a very large airborne gap, even 20 dB improvement, patient will be very happy. But what will you call a successful operation?
If we stay basic, success is an airborne gap of less than 20 dBs. For me, a success is when a patient said, "Thank you, doctor."
You know, the problem is that when we talk about stapedectomy, the situation is more or less the same all over. I mean, but here it depends on the situation of the mucosa, if it's an inflamed mucosa or it's normal mucosa, on the absence or presence of ossicles. So what Denise says is absolutely true. I mean, you cannot measure like you do for stapedectomy 10 dBs, 20 dBs or less or more. Is the patient being satisfied? And you have to take into consideration also the long-term run, because the long-term run of ossicular reconstruction is not the same as the long-term run of stapedectomy. In the end, results go worse and worse over time.
I think we are all fixed to this idea of getting an airborne gap closure of less than 20 decibels. But if you look at what the patients want to be able to hear. So I've got patients who we have just barely made 20 decibels, but they say, "Thank you, doctor, I can hear my child cry. I can hear the fire alarm, I can hear." So it's very subjective. So I think it's very difficult to, it's very difficult to do that.
And conversely, sometimes you see patient with a closed airborne gap, you said, "Oh, I'm the best." And the patient said, "I'm not sure I hear better."
I think one of the thing is we should not report on success, but only results. My teacher told me, don't speak about success, report the results and let the others decide if it's a success or not.
It's about the same as it's the same as the chord tympani on stapes surgery. Don't ask your patient post-op if he is having any problem. If he has, he will tell you. But once you start, "Oh yes, doctor, I have a problem." Now you ask me, I have. So.
Good question.
Yeah. How many of you use the incus to do reconstruction? The incus in this case with the malleus and the strip.
So what materials do you use? Incus or other prostheses?
Or how much do you use the incus? In case if you have the TORP, do you prefer incus or not? Or
I prefer no incus, no TORP, no POP where there is a stapes. Sometimes we use the incus to learn the resident to drill an incus. Okay, but we use systematically the double block of cartilage on the stapes head with very good results. It's natural, it's costless, even if I work in Rothschild Foundation, okay, and it never extrude. On the other way, if there is no stapes, I use titanium prosthesis, and I don't care of the malleus. It's a struggle with Marseille.
Yeah, but that's another similarity between France and Germany, at least with Paris. We don't care about
Paris, not France.
Well, I think
Paris represented France wonderful at the Olympic Games.
I think incus transposition was a very good approach. The problem was when there was cholesteatoma, you shouldn't manage the incus if you still have cholesteatoma. They may be inclusions, cell inclusions in the bone. But from the extrusion standpoint, it was much better than the artificial prosthesis. But the fact is that it's much easier to open a prosthesis than to carve a good incus for just to put it as a transposition. But I still like the incus as a good material for hearing reconstruction when it's available.
Okay, I saw many people moving their head and agreeing with what you said. So I apologize. You have missed your topic. You should point out the controversies and please continue and put the finger for the.
Okay, can you hear me? Yeah. Okay, so, well, first of all, Robert, thanks a lot for allowing the hearing to be here in this conference. Congratulations for 25 years, and here's to the next 25. We hope to be here for the next 25.
Look pretty old for a 25-year-old guy.
Okay. Anyway, this topic is very appealing to me because it makes me go back to when I was 25. When I was young, I learned everything I know about middle ear surgery, and this course, this is me in 1982, and I learned everything from middle ear surgery.
You didn't change at all.
Yeah, well, that was me. That was my father, and my two teachers were my father, and you know this guy, Robert? He's Toño de la Cruz. He's Antonio de la Cruz. He was a very close friend, and he was a master. And well, 16 years after this picture, we were sharing together conferences on the same topic. But you know, time is cruel, and 45 years later of this time, persons have changed. In fact, Toño passed away, unfortunately, several years ago, and others became a bit older than before, but they keep quiet because controversies are still the same. So I have been discussing for 45 years the same topics, and they are still here. So there are classic controversies, and I will just let you know what they are, and we will discuss later on. Canal wall down versus canal wall up, mastoid obliteration and posterior wall reconstruction, one stage versus two stage operation, operating a dry ear or waiting for the ear to, wet ear or waiting for the ear to get dry. Underlay, we discussed that, overlay or under overlay techniques for grafting, and fascia versus cartilage versus other graft tissues that was also discussed before. And we have some, I wouldn't say new, but more recent controversies, which are basically endoscopic versus microscopic surgery, diffusion-weighted MRI versus second look, and subtotal petrosectomy versus conventional surgery. Just to give you my view after 45 years of reflection and discussion of these topics, I think both canal wall up and canal wall down have their indications, and if possible, I will prefer canal wall up, and we will see if this is agreed by the others. I don't like mastoid obliteration. I don't like posterior wall reconstruction in general, so they're not my favorite. I prefer one stage or two stages, depending on the situation, as we mentioned before, and of the patient and the disease. I'd rather go dry, but maybe going wet, it's also an option. I like it more underlay, but again, this is something that we will discuss one more time after 45 years.
Are you going to politics or?
Yes. I'm planning. You know, my government is changing, so I'm planning to apply for.
No, you're not politic. You made personal surgery.
Absolutely.
And we are at the era of personal medicine.
Absolutely. So I think this is something that I think the era of the protocols and all people doing the same coffee for everyone, it's changed, and this is not the time now.
Javi, let's wait a moment. If we do personalized surgery, both have their indications. If possible, canal wall up down. Give us a little bit of guidelines.
Okay.
And then we hear the opinion of the audience.
I think it depends on the extent of the cholesteatoma, on the situation of the patient, and again, like we said before, it depends on how easily will you follow up this patient. If the patient is going to come to you and you are able to make MRI with diffusion weighted images, then you may keep the canal wall down and the canal wall up and keep a normal ear. But if the patient is going to go away and you will never see it again, him again or her again, then a canal wall down probably will be a much better decision. So it will depend on many factors. But I was waiting for the discussion, so I'm just showing you my basic ideas. And concerning the new controversies, and I don't want anyone to be mad on that, I'm too old to play the pirate. I like to operate with both eyes and both hands. Having one hand tied to the back and having one eye closed is not my idea of surgery, but this is just a problem of age. And of course, endoscopes are wonderful to show images and to teach people. But for surgery, give me both eyes and both hands. Diffusion weighted and versus MRI it will be cholesteatoma dependent. I think MRI right now gives you a very good approach to cholesteatoma recurrent or residual. And finally, I love subtotal petrosectomy in selected cases. For some patients, selected cases, subtotal petrosectomy is the best solution. In a nutshell, if we're still debating this after 45 years, maybe it's because multiple options are useful. The main difference between 1980 and today are hearing implants. Nowadays, in my opinion, doing more than 2 tympanoplasties for functional reasons, not for cholesteatoma removal, but for functional reasons, does not make sense. Once you have failed twice to recover hearing, there are other solutions, and these other solutions in radical cavities with conductive or mixed hearing loss and a draining ear, bone conduction devices, or sound bridge with subtotal petrosectomy are magic, at least in my experience. So the take-home message is beware of dogmas. There are no dogmas when after 45 years we're still debating the same topics. And in the literature, you can find arguments in favor of any option and also the opposite. So before telling you goodbye, you're all invited to the next International Facial Nerve Symposium in Madrid. It will be in September this year, 24 to 27. Madrid is very close to here. You can go. We will love to have you there.
Motorbike.
By motorbike, yeah. Well, actually, I did that for this meeting. And it's organized by Luis La Saleta and myself, and we will love to see you there. Thank you very much.
Thank you, Javier. Thank you for reflecting 45 years. And one conclusion I have is we have even more controversies than 45 years ago. So which of the controversies are you most interested in from the audience?
There are two things which I would like to talk about. One is the posterior canal wall reconstruction. It's something which gives patients a cavity-free ear. And you can just obliterate the cavity and then you can do a posterior canal reconstruction, whether it's by bone chip or with the cartilage. And it gives the patient a very good ear. And the patient is free. If he goes away, he swims, he does anything. It's a very good thing, because sometimes while we are teaching the residents, they open up the dura and the sinus. And while giving a canal wall down cavity, open cavity to such, does all the things. So it's very difficult. So if canal wall reconstruction is done, these patients are very happy with the results. So I don't see a controversy in constructing the canal wall again if we have cleared the disease. And the second thing is, you showed a picture of a pirate with the one hand and one eye. So if a surgeon is given the second hand, like nowadays endo holders are used, like endoscope holders are used, which can be mounted on the microscope, or they carry standalone endoscope holders. So you have both your hands. You have, because we are all trained in endoscopic sinus surgeries, so we have that advantage of using that knowledge for endoscopic ear surgery. So two-handed endoscopic surgery takes that disadvantage also of a pirate, and the posterior canal reconstruction takes the patient, makes the patient very happy. So there should be no controversies in these two things. I mean, when we are looking at the evidence of this.
There should not be, but the fact is that there is. I mean, we are discussing about that because I'm not convinced, even if I'm a pirate with just both hands and even only one eye. I like the image. I like the image of a microscope because I've been trained on a microscope and I've been 45 years using a microscope. So I think the microscope for the ear surgery is a basic tool. And the difference between endoscopic sinus surgery and endoscopic ear surgery is that endoscopic sinus surgery moved to be routine in a very short period of time. Abdominal surgery became routine in very short period of time. And ear surgery, endoscopic ear surgery, is not yet having this speed. It's like thyroid surgery. Endoscopic thyroid surgery is not going like that. The same people that were doing at the beginning are doing now. And with the ear, it's maybe a little bit faster evolution, but the fact is that it's not so convincing that we all do that. So this is why it's a controversy. And concerning the posterior wall reconstruction, my results are very poor. Using or cartilage or there's prosthesis that hydrocelapatite prosthesis that reconstructs the posterior canal wall, and my results are not good. So this is why I'm not in favor of that, and this is why it's still a controversy.
But we have heard about curved cartilage from the concha for the ear canal reconstruction. So I personally feel this is a good option. Depending on the extent of the cholesteatoma, if you follow the philosophy of removing the cholesteatoma on the way of origin, and I think this plays also a role to decide which way you want to go.
For me, the main interest of the obliteration is to maintain the cartilage, not to obliterate the mastoid. I don't care about that.
In fact, sorry. In fact, it's better to support the posterior canal wall with obliteration than obliterating the whole cavity, because then the aerated mastoid, the principle of aerated mastoid goes away if we obliterate the whole cavity. So if we support the cartilage from behind and leave the rest of the mastoid as ear cavity, it is better then. So
yeah, but if you see these reconstructed posterior canal walls in the long-term run, it will retract and fall back to the cavity and will end up with, so to say, a smoothened cavity. So it really depends on the extent of how much you have taken down the canal wall. Yes, please.
But if you use cortical bone, that does not become a problem, because I just drill out a cortical bone, measure it, chisel it, and then basically make a groove and put the bone back in to recreate your posterior canal wall, and it looks fine. Because where I work, you cannot tell the children to not swim.
Yeah,
they will in New Zealand. They will all go to they swim in school in summer. Almost every week. So they won't listen.
Well, this is the argument for canal wall up or reconstruction of the canal wall. But who has experience with re-implanting the bony canal wall? What are your results? I know the results from Feldman in the early 70s, and they had a saw, and they cut out the wall, and then it was replaced, and it was degenerated. So what are your results with that?
Yeah, thank you very much. Results are good, because I always obliterate to the mastoid, and I fill the mastoid up completely, because in time I used to not fill it completely, and then the posterior wall fell back, and now I do the obliteration with the bony ear canal, get out and then replace it. And sometimes you place muscular flap on top of it to vascularize it. So the result is really good in my hands. Yeah.
Yes, of course, in your hand. The other case come from Alio Loco, as we have heard. Do you fear, or how do you control recurrent disease of the cholesteatoma? The main argument against obliteration is you grow and dig epithelium into the depth. That's
no, I've never seen it. So we do non-EPI MRI to check it, of course, to follow up.
But I draw.
But to control it, you fill the gaps. So sometimes fascia on it, or muscular flap, or you need soft edges. So no gaps, but only soft edges, and then it heals really good.
Well, with non-epi DIV, we have the pioneer here sitting on the panel. Coming last year from the course, I was very optimistic that this would be a good way of control, and there's a poster of Dr. Schreier and Dr. Sophia Ganner outside, and when we looked at the own data in collaboration with our radiologist, this was just discouraging. So I think this is another controversial topic which needs to be discussed in the future. And so far our conclusion is second look is even more important. Or we have to train our radiologists or better classify.
Probably.
Another controversy I missed is the Eustachian tube dilation. I was in an American academy, and everybody talked about it. It was like the hammer and the nail, and I didn't hear about it. So in the Netherlands we don't do it, but in a lot of countries everybody talks about it.
You're still doing second look surgery, systematic revision second look surgery in Netherlands?
Not only for sometimes hearing improvement, but not to check cholesteatoma.
Not to check cholesteatoma. No. You don't have a recurrency. Residual disease.
Yes, but that's not second look. That's revision surgery.
So you perform the second look surgery?
No, I only do revision surgery when there's recurrence of disease.
Prep. When do you do second look?
It's a good question. So I'm looking at it in the context of Asia. Yeah. So I've had to revise surgeries done elsewhere where they've obliterated and there was cholestoma recurrence.
From Asia, so to say.
Yeah. So when there's a cholestoma recurrence after obliteration, it's an absolute nightmare, especially when you didn't do the surgery. So I've had the misfortune to brain abscess and meningitis because there was a cholestoma after an obliteration done by someone else. And for me to revise the surgery is an absolute nightmare. So if you obliterate and then you need an MRI scan to make sure there is no recurrence, it's fine if you're from a country where MRI scan, it's free. But for us, the patient has to pay. So if the patient has to pay for MRI scan, they will not come back. So I would rather leave the cavity open. I tell them, if you want to swim, just buy the ear plug, put oil and swim, and they are quite happy. So I think it all depends. There's no right or wrong answer. There's no controversy. It's luck of the draw. Where are you born? MRI scan is covered by the government, then it's fine. But if you're in a place like mine where it's not as hot as here, I think then you just leave everything open and it's much safer. But can I go back to something that Robert said that I agree very much. So Robert said that you must, even if you do endoscopic, you must be able to do microscopic, and I absolutely agree. A scenario came to my mind. So we've had this problem now in a neighboring country where the younger generation are doing endoscopic cholecystectomy. So they have not been trained in open because cholecystectomy is all done endoscopically now. Now when they have bleeding, they cannot control the bleeding. They have to call the senior guys to come and do the open one because they are not trained. So I think you should not do an endoscopic ear surgery unless you have done enough open surgery and you can convert if required to. Because can you imagine someone doing an endoscopic cholecystectomy, you have bleeding and you can't control the bleeding and the patient dies. The same thing can happen with us as well.
And I agree. Yeah?
I remember when we were, doing the Live International Otolaryngology Network Live. Moaz Tarabici was also trying to perform endoscopic removal cholesteatoma. So he chose atypical cholesteatoma, and of course he's very expert in endoscopy. But in 2 times, he had to convert to microscopy. So for the young generation, I think it is a very important message to learn both and not only one.
Well, I think about education, what you mentioned is, I think the 3-dimensional view of the microscope is important. And what we have seen is a much steeper learning curve, and Robert Minsky in his department pointed that out at the otosclerosis meeting. They have a 3D microscope and a 3D monitor, as we had with Helms in the early days. And the students learned faster if they had a 3D image of the surgery and could follow in 3D. So I think this should be the precondition to proceed in either way later on if you have experience in ear surgery. But a substantial education should be mandatory.
I won't be here tomorrow because I have to go back to Paris quickly because I have a match. But Jan Lazar will speak tomorrow about exoscope.
Yeah.
And probably the future is to combine endoscope and exoscope on the same machine.
I completely agree. I'm looking very much forward to that. We have more controversies tomorrow, and the exoscope is really a third alternative. So we have next year more controversies, but I'm looking a little bit on the clock to be on time. Well, it was intended to have a last presentation on aftercare. I just want to raise quickly some points, but being the last in the discussion row, the dog bites the last, and we have a little bit more of controversies between white wine and red wine in the evening. And I think this is more important.
I don't think there is any controversies in this.
Okay, then we close the day then with
maybe Jose Carlos can talk about that.
Right. Yeah, well, just address that we have addressed surgeries, and aftercare is important. It is often underestimated, and there are some principles about the package. We have seen different types of packages. We are always using silastic sheeting. We'll use a proper bandage. We have seen today, Robert, with silastic sheets and the Merosale. We have seen Merosale without silastic sheeting. So there are many ways, and I want to just create a little bit of discussion what is known and what is feeling how aftercare should be. We leave the package for 3 weeks. I don't know how long you will leave it, but there are no hard data on how we should confirm the aftercare. Everybody does it in a way how he had learned it from the teacher, and somehow it works well, and that's how we do it. But there are no statistical data on available how we use it. So we use silastic, we do Weber and Frenzel, we do a tuning fork test even in an in or outpatient procedure, and we change the daily. When we have the wound control, we should also have a look behind the ear. This is a friend of Northern Germany who has sent this to me 2 weeks after surgery when the patient presented at him. Also alio loco. Granulations are removed with micro scissors or forceps. For infections, we give local antibiotics, and we do, if we have a reperforation, sheeting with cigarette paper. We use ointment and antibiotic drugs and silver nitrate for itching. One personal question: who of you has access to Solutio Castellani in original composition? We don't have it anymore in Germany because of the Fuchsin is called to be carcinogenic. Has anybody access to Solutio Castellani?
Which millésime?
Yeah.
Huh?
Which millésime?
Vaginal solution. No,
Okay.
I have no experience of vaginal solution.
Yeah, but it's a off-label use. And yeah, what is about
Castellani solution?
Yeah,
it was fantastic.
Yes,
to
it
try
was.
it here. It was.
Yeah,
because it's no more available.
No, in
and
our
for
country,
my
not-
range is this.
Huh?
My range is this.
Yeah,
it was very, very interesting.
Valsalva maneuver after ear surgery. What is your opinion?
No problem.
No problem. You force the patient to do it, or you avoid it?
No, normal.
Just normal. So as it is. Okay, airplane we have discussed in the morning, 4 weeks. Scuba diving is open. Depends on. We are in a lucky situation in Germany. We have special scuba diving doctors, and so we give the responsibility to them. They have recently made guidelines, though, that ear surgery does not speak against scuba diving, but the responsibility is not with the surgeon, but with the scuba diving doctor. And for aftercare, you need patience. It needs time to heal. And if you have no more question, yeah.
Thank you for opportunity to ask this question. My question about cholesteatoma, about pediatric cholesteatoma, how long should be follow up after canal volap surgery in the cases of pediatric cholesteatoma, and when we can provide hearing reconstruction, because second surgery should be done for reconstruction if we have no any suspicion of recurrency.
Okay.
How long should be follow up before reconstruction?
Who wants to answer?
We wait between 6 months and 1 year for a second look.
Okay, for pediatric cholesteatoma, our database and the literature, as far as I know, says that you have recurrency between 18 and 20 months, at 5 to 7 years, and at 25 years. So you have to follow the patients lifelong, and we do always one stage and reconstruct in the first session. So there's, in our concept, no need for a second look, so to say, to do the hearing reconstruction. This is different in other schools, but then I would follow Javier and Dennis to maybe after 6 to 12 months for the hearing reconstruction. But for the recurrency, you have to wait at least 25 years, because there are published data from Scandinavia that you have peaks of recurrence at 2 years, 7 years, and 25 years. Please.
Okay, I have a question. What do you with what do you with those patients that you make a stapedectomy and you close the gap, but they are still complaining about the results, that they are not happy about the results, but you close the gap?
This is a question to Robert. Well, we would send the patient to Béziers, and then we solve the problem.
I think you have a patient in front of you. And I said some patient come, the airborne cap is closed. I say, so what, are you happy? Oh, I'm not sure. What do you think? I said, look at the audiometry test. I know that I heard better. Okay? So with the patient unhappy, you have to deal with, because it's very often, except if you have a complication, of course, but when you have a good result, sometimes you are surprised because the patient said, I don't know if I heard better. And you show the graph, and they say, yes, it's okay. And that's the way I do. And I don't ask too much the patient, like Robert. If they have problem, don't worry. They will tell you.
Well, if the patient is not happy, what sometimes helps if you do a speech audiogram and show the speech audiogram before and after, and can demonstrate in word understanding what the improvement was.
I have 2 comments for the previous questions. In Necker, that's the reference for pediatric, they recommend MRI at 18 months, if you can do MRI, of course. And when you have a nice result, but the patient complains, I ask a speech therapist to help, because sometimes you have, I don't know, plasticity reconnections that you need to help and train.
What is your detection rate with the MRI?
5 millimeters. So you have to be careful. It's not because at 18 months it's negative that you have to say, okay, I will see you later on. It depends also when you do the surgery. I think you have to write down within the report if you're happy with the removal, if you think you followed everything, or if you lost some part of the cholesteatoma. And then I write down it on my report. Yep. I do write it on, and I may change the frequency of MRI if I'm not happy during the surgery.
Right. Yeah.
I have a strange
Behind,
question.
and then Manoa.
Okay.
No, I never do second look without MRI. I first do an MRI, and depending on the result, I go or I do not go. And depending of my surgical impression, I may not wait 5 years more to do the second MRI, but maybe, I don't know, 2 years or 1 year more. But
Again,
it's true. We're a very wealthy country, so it's easy.
Let's meet tomorrow with Sophia and Andrea at their poster, please.
Excuse me, if you have a complication with your patient, like facial nerve palsy or failure, I ask all the panelists and all the audience, what is your feeling after that? And I hear about that a lot of doctors have a depression because of this action.
Oh, so which complication do you mean?
Yeah.
Facial nerve palsy?
That's number one. Even
direct after surgery or delayed?
Direct after surgery and failures, all type of failures.
Let's stay with the facial nerve palsy, and we ask around, and we ask the audience, and then we'll end up at 9 o'clock. But maybe we have to. Let's ask about. Well, it's a good question about the feelings of the surgeon.
I think facial palsy for me would be the most difficult thing to accept. The other one is also difficult, but then you can accept it. Facial palsy is a problem because the patient is just showing the complication every day you see him, and it's very difficult to accept for the patient too. So I would say this is the worst for me. I would say I never had any for stapes. I had one in chronic ear surgery, and it's difficult always. More than a dead ear. Dead ear is difficult, but facial palsy is worse.
Facial palsy. Sorry, facial palsy. And what I do, I don't sleep.
Yeah.
For many
weeks.
days, I don't sleep.
Well, I feel miserable if I have a facial paralysis. I didn't have facial paralysis in middle ear surgery, but I have hundreds of facial paralysis in skull-base surgery. So this is why we organized the facial paralysis symposium, because we are experts on that topic. But I feel miserable because I feel myself responsible of something bad that happened to a patient. And when I always say the same. I mean, if you work with cars and you have an impact in the car, you fix it up and everything goes right. But when you do something and the patient suffers for the rest of his life, that's a serious problem. So, but if I will not be feeling miserable, I will stop doing surgery because I will be dangerous.
I think if you have done enough complex surgeries, you will have complications. It's virtually impossible not to have complications if you do complex surgeries. If you have done enough complex surgeries and don't have complication, you haven't done enough. I don't think any one of us can run away. So the only thing we can do is do the best we can, be honest to the patient, and the rest is God's will. That's the best we can do.
Well, facial palsy is a disaster, and one of the main things is you should work in a team and have colleagues who help you to overcome the depression. And luckily, in my career so far, I experienced 3 facial palsies, delayed, permanent, and no permanent, but transient. But as Dennis, it gave me a few days of no sleeping and really difficult times, because this is really the disaster you can have, and you have to ask yourself, what could I have done better? But when it happens and you need to go in for surgery, you should go to somebody else whom you trust and let him do the surgery also for medical legal aspects, and get an objective description of what you found, if you made a mistake or if it's on occasion of the disease, and not try to solve something that you did not realize under surgery by yourself.
Can I come back to one of the earlier points, which was what do you do with the unhappy patient, and how do you measure success? And one thing we didn't touch upon is selection of patients in the discussion. And one of the things we didn't talk about was the opposite ear, because if you're doing stapedotomy and they have bilateral conductive loss, and they're going to notice a gain, whereas asymmetric loss. So the happiness of the patient are going to depend on the overall function, not just on that technical closure of the ear bone gap, and that's an important point in the selection criteria. Even closing a perforation, if they can use a hearing aid better without discharge, there's a big difference to them versus the technical ear bone gap. So looking at success and patient happiness more than just the ear bone gap, it's about the ability to hear in the sound field, and that's not just the technical result. So selection is really important.
Okay. Well, at the end, I need to have another question to the audience. What can we do to make the doctors and the speakers happy in the evening after we had this discussion on depressions and facial nerve palsy? So I would come to an end and thank Robert for trying out this experiment. And I like to thank all the speakers and the panelists, and especially to the audience for the lively discussions and for the discussions and what we have learned out of that. Thank you and happy evening.